We differentiated between various bone and joint infections and listed common microorganisms associated with vertebral osteomyelitis or prosthetic joint infections. We selected effective drug therapy for treatment of bone and joint infections, and we avoided drugs that lack bone penetration for treatment of osteomyelitis. Now, given a patient case, let's select total duration of therapy based on patient-specific parameters. For native vertebral osteomyelitis specifically, total duration of 6 weeks of parenteral or highly bioavailable oral antimicrobial therapy for most patients with bacterial NVO is recommended. Of course, a total duration of 3 months of antimicrobial therapy is recommended for patients with NVO due to Brucella species. The rationale behind the prolonged duration mostly stems from the limited bone penetration of most antibiotics in patients with NVO, the need for several weeks for bone to revascularize following surgery, and the limited experience derived from trials in pediatric patients with hematogenous long bone osteomyelitis. For patients with prosthetic joint infection who retain the prosthesis following debridement, if the prosthetic joint infection is due to Staphylococcus species, then pathogen-specific IV antimicrobial therapy with addition of PO rifampin is recommended for 2 to 6 weeks. Of course, if the patient cannot take rifampin, then the initial therapy should be 4 to 6 weeks. And then once this duration of therapy is complete, the patient will switch to complete oral antimicrobial therapy, and the duration of that depends on the type of arthroplasty that the patient received. Now, if the prosthetic joint infection is due to organisms other than Staphylococcus, then 4 to 6 weeks of either IV or oral antimicrobial therapy is recommended. Of course, indefinite chronic oral antimicrobial suppression may follow the above regimen based on in vitro susceptibility, allergies, and intolerances. For patients with prosthetic joint infection who have resection arthroplastic, either with or without reimplantation, pathogen-specific IV or highly bioavailable oral antimicrobial therapy is recommended for 4 to 6 weeks. For patients who get amputation, it's important to make decisions based on the culture results from residual bone and soft tissue following amputation. If after 48 hours nothing has grown in the cultures, it's appropriate to discontinue antibiotic. Otherwise, if something grows on the residual infected bone and soft tissue, then the culture results should be used to direct antimicrobial therapy for 4 to 6 weeks following surgery.